All right. So we have two chapters to finish up today. Um, chapters 15 and 16. So we're going to talk about healthcare settings, and then we're going to talk about health insurance. So how healthcare system is financed. And then hold on one second. Your exam review is Sunday. Let me just pull up the announcements. Um, so your exam review is going to be Sunday at 8 Eastern. If you can attend, I will post the recording as soon as it is available. Um, for some reason, I don't know why. If you ever wonder why sometimes it takes me a little while to post um your recordings, for some reason my Zoom takes forever to upload the video and then convert it over. So I don't know why. But that's so as soon as the recording is ready, I will post it. Um, so again, next week we will have exam three. Right after exam three, we will do our HESI review. So there won't be a separate HESI review. It'll be right after exam three. Okay. So, and then of course that will get posted as well. So we'll start with chapter 15. So again, chapter 15 is all about different
Um,
healthcare.
Miss
Yes, ma'am.
Martina, when would the papers be graded?
Um, so I don't put the grades in until everybody has been done. So I'm about halfway through.
Okay.
So they'll be done soon. Mm. All right.
I
I
got a
will
question
share.
about that too.
I'm
I don't know if you see my email, but I had a weird mark by mine. I don't know.
Let me look at it real quick. Winnie, I think yours is because it didn't go through the there's a couple people for some reason they didn't submit right to the plagiarism checker, so I can resubmit those. Yeah, that's what it was. I'm resubmitting them now.
Okay,
All
thank you.
right. All right. I will share my screen. All right. Y'all can see the PowerPoints. All right. So, ooh, that's like really small. Let me make that bigger. All right. So healthcare settings. When we look at, there's obviously many different types of healthcare settings, or healthcare agencies. They are not the same. They can differ in size, they can differ in focus and quality of service, how they're financed. And so if you're looking at, places that you potentially want to work when you graduate, you want to make sure, right, that you will always, and this is just general purpose, you always research the organization, right, that you're going to work at, so you can have that information when you go. Um, so all of your healthcare settings are going to offer a variety of services, right? They can be owned and operated by the public, which is government entities, or they can be private entities, which include both nonprofit as well as your for-profit or proprietary. So we'll start with public, okay? Um, Oops, sorry. All right, so your public, there's two types of public healthcare agencies. We have official, and voluntary. So here's your official column. Here is your non-voluntary or your non-official voluntary. Official government healthcare agencies are supported by tax money. They are accountable to us as taxpayers as well as the government. Their primary emphasis is on the delivery of disease prevention and wellness promotion programs. and they provide direct healthcare services. Your voluntary healthcare agencies are supported by voluntary contributions, as well as charging a fee for services. And many of those are going to be based on the financial ability to pay. They are generally aligned with public opinion, but are accountable to their supporters. Their activities that they offer are determined by the supporter interest. They're not legally mandated. They have an emphasis on education and research, and they may also offer some direct healthcare services. Um, and some of the, so we'll go to the next slide. So again, your official, right? Your government, agencies here. These are public health agencies. So some official and voluntary health agencies operate at the local, state, and federal level. So at the, let me go to the next one. At the local level, we have the county or the city health department, whichever one your area has. They are funded by local tax money, as well as they may get some subsidies from the state as well as the federal levels of government. They carry out state laws concerning community health, which are what we call mandated programs. They also can carry out some non-mandated programs like health promotion programs. And then in collaboration with other government agencies, they respond to community health issues. So like if there's an outbreak of a contagious disease, um, chicken pox, measles, something along those lines. I know it just depends on what's going on in the area. Your state Each state has a health department as well. And so it's funded by state tax money. They will sometimes get subsidies from the federal government as well. And then we have our federal. So the federal is at the national level. That's the U.S. Department of Health and Human Services, or HHS. It is funded by federal taxes. And it's the head of the agency is someone that is appointed by the President of the United States. And so that person is going to advise the president on health matters, within the country. It has 11 operating divisions, including 8 agencies within the U.S. Public Health Services. So the variety of those, many of these you have heard of before. So we have the U.S. Food and Drug Administration, which is your FDA. They're the ones that make sure all the food, the human and animal drugs, biological products, medical devices, and electronic products that emit radiation are safe, and if applicable, effective, right? So all your medications, all our foods, even like think of like your hip implants, your knee implants, your pacemakers and defibrillators, those things like that. They make sure that all of those are safe for use. We have the Centers for Disease Control and Prevention, which is your CDC. They provide leadership in health prevention and promotion, as well as respond to public health emergencies. And then we have the National Institute of Health, which is your NIH. The National Institute of Health, they do biomedical research in their own labs and universities, hospitals, private research institutions, as well as the private industry. They also train new researchers, promote collecting and sharing of medical knowledge. There's 27 institutes and centers, including the National Institute of Nursing Research. Did you guys know we had a National Institute of Nursing Research? And then some of your voluntary agencies. These voluntary agencies, or non-official healthcare agencies, they're nonprofit. They, usually meet the people or meet the demands of people with specific diseases, and certain segments of the population. Um, there are paid personnel that work for these organizations, but mostly volunteers that support. So again, some of them, your American Cancer Society, the American Diabetes Association, American Lung, American Heart. What else would fall under here? Your American Stroke Association, your Alcoholics Anonymous. There's an ALS Society, La Leche League, Easter Seals, Narcotics Anonymous would be one of these as well. So pretty much, and I mean, this is just, there's even
Okay.
more of them out there. But there's a lot of volunteer agencies out there. So even when we're working with clients, right, and we're
See.
trying to find some community resources, some of these may be some good resources for your clients. All right, private healthcare agencies. Most of us are more familiar with the private healthcare
Well,
agencies. And
what
so
happened?
generally speaking, when we get into the healthcare,
Okay, when I was done with it.
who is Kareem, I'm gonna mute you, okay? Um, Destiny, do you know your camera is not on? I don't know if she knows her camera is not on. Um, so most of us, right, we get entrance through the healthcare system through private healthcare agencies. And these again are going to include proprietary, which are your for-profit or your nonprofit. Um, Curing disease and illness with disease prevention and wellness are some of the key aspects of your private healthcare agencies. They also generally will offer traditional, like your acute care, your long-term care, home care, outpatient services. Um, Family practice. So, not of course, not everybody has a family practice provider, but primary care, family practice, right? That's where we, you get your yearly physicals. You get sick, you need to go see a doctor. You call your your primary care provider. They provide diagnosis, they provide treatment, and then of course their patients are billed for those services. If you need further testing like x-rays or CT scans or, something along those lines, generally you're going to go to a specialist, right? Um, so they kind of just mediate the care, first, for you. So, you need a specialist, you go to your primary care, they'll help you find a specialist. They'll get those results, right? And kind of be the intermediary for you, um, as a result of that. Private practice nurses are your advanced practice nurses. So your nurse practitioners who can counsel and consult people as well on healthcare issues. This is especially important in our rural areas where they may not have access to, physicians, doctors, that kind of thing. Um, so there's a big practice for that as well. And then we go into the different types of hospitals. So we have community hospitals, we have federal government, or we have non-federal psychiatric hospitals, right? So our community hospitals. So community hospital, you will, provide most, medical services that we need. Um, in your acute care, right? You have an emergency room, you're sick, you're injured, you go to the emergency room, then you might get admitted into the hospital, so they will provide that acute care. Um, they may not have specialists for serious conditions. Depending on your area, especially in some of the more rural areas, right? They may not have a specialist for everything on staff. So they may have to transfer you right to another hospital or somewhere else that would have that specialty. Um, Specialty hospitals, these are a little bit different. They offer services related to a particular disease. Trying to think of like some of your rehab hospitals, things like that. Like you've heard of like heart centers or even orthopedic centers that focus on those specific specialties. They generally have highly skilled specialists with advanced knowledge, um, and offer a variety of services within those. Your voluntary or your voluntary community hospitals, um, these are community associations or religious organizations that operate community hospitals. So some of your religious organizations, like I'm sure everybody's heard of St. Jude's, or Shriners Hospital, right? Those are your, more community hospitals. And we know that they're nonprofit because they always have those telethons that make you want to cry every year when you're looking at all the kids. Um, they are heavily dependent on gifts and donations to supplement their sources of revenue. Again, that's why they do the telethons and the fundraisers throughout the year, so that they can support the hospital itself, of course, as well as the patients that are there. There's usually a paid administrator, but there is always a board of administrator or board of trustees, as well. Your federal or state government hospitals, which are your public hospitals. So these are going to be like your Veterans Health Administration, the state, county, um, municipally owned and operated nonprofit hospitals, hospitals for people with serious mental illness. Those also continue to be funded by federal, state, or county funds. So, some of your areas that you may live in, right? You may have like a state psychiatric facility nearby. Um, my mom was a psych nurse. She worked at a state psychiatric facility in New Jersey. She loves psych. She loved psych. I am not a psych nurse, not a psych nurse. But you may see some of these hospitals in your areas. Veterans Administration, your VA hospitals. They, kind of are a little bit all over. Some areas are more heavily concentrated, with VA clinics and hospitals, depending on their population. Others may have just smaller. Um, but I will tell you, I've never worked for the VA, but I've had lots of former students, as well as friends that work in the VA. And if you're really, if you're interested in working with veterans, the VA is a really good place to go work if you can get in. Um, they have lots of benefits, even to help you go back to school and pay for education. Um, and then even within like, say, off the top of my head, I don't remember what, like, say you're living in Ohio and you want to move to, I don't know, Florida, because everybody wants to move to Florida. Just kidding. But let's just say that's where you want to go. If there's an opening at the VA hospital, then you can always transfer within the VA system so you don't lose your seniority and all that stuff. LPNs at a 15,000 sign-on bonus. That's amazing. That's awesome, Julianne. So Julianne shared that there's an area that is looking for LPNs and they have a $15,000 sign-on bonus. That's really awesome. That's
Yeah.
pretty significant.
And tuition reimbursement.
Yeah. So they do offer tuition reimbursement. That's one of the really good. Then some of the other benefits within the VA system is really good as well. Um, I know in Virginia, I was talking because, I was in Virginia. I was talking to some of the Virginia students in one of my other classes. So they had just built, um, So where we live in Virginia, where I lived in Virginia, is really we had like 10 military bases. And they only had one VA hospital, which was always impossible to get in. But they built a brand new clinic. And I had we similar conversation. We were talking about, this information. And had read an article that the clinic had just opened. It's been open for not just, it's been open for about a year now. And they were saying that there were, I don't remember if it was 200 or 300 vacancies. So for whatever reason, they hadn't even been able to staff the clinic completely. So I was like, I don't know what's available. I didn't go on USA Jobs or, VA.gov or anything like that to see what jobs were available, but that's a significant amount in openings, and I'm curious as to why they haven't been able to staff them because, there's a nursing shortage everywhere. So I thought that was really interesting. But I just know I use the VA for myself. My husband uses the VA as well. Um, and everybody that I've come across within the VA system seems to really like working there. So, all right. Um, I gotta take this back down because it's gonna drive me crazy. Um, all right, teaching and research hospitals. These can be either community as well as federal government hospitals. They are training sites for healthcare professionals. They treat clients with serious or unusual conditions. They do research. They develop new treatments. They do clinical trials. They're almost always affiliated with medical schools. So you have access there to those highly skilled practitioners. So like your John Hopkins, Boston University, Vanderbilt. I mean, there's more out there. Those are just the ones that come to my head. I know in Virginia we had Eastern Virginia Medical School, which was right there on the campus with Children's Hospital and one of the other big hospitals in the area. So there was lots of collaboration between those three areas. And then critical access hospitals. So access hospitals, they are small, no more than 25 inpatient beds. The average length of stay is no more than 96 hours for acute inpatient care. It is still 24 hours a day, 7 days a week. Emergency care as well. But these are located more in your rural areas that have at least a 35-mile drive away from any other hospital. So the critical access hospitals, they will do common conditions and outpatient care. But for more serious injuries, illnesses, they can stabilize the patients and then either refer or transfer them to a larger hospital. Um, Most of us are familiar more with the ambulatory services. Um, these are located in private and public sectors. So it could be your outpatient hospitals, your nursing care centers, your HMOs, your community health clinics. These are generally less expensive. These are for people who either live independently or are cared for at home. They do assessment, treatment, care coordination, but this is also your healthcare provider's office. It's some of those freestanding ambulatory centers, like your urgent care centers, right? I don't know, Virginia, we had urgent care centers, there were a few down here. I just thought this was so odd. Um, I would say within about, I'm trying to think of I want to say in about, I would give it a 3-mile radius. There is about six different urgent cares that I can go to. They're like, how you have like little strip malls, here and there. They have them in the strip malls. And so I never ever see anybody there. So I'm like, you're really curious if how they even stay open. But there are urgent cares everywhere here. I've never seen so many urgent cares, and freestanding ERs. Like, there was a couple freestanding ERs where I was in Virginia. Down here, they're like almost as common as the urgent care centers. They're everywhere. Um, so big change for me. Um, but again, it could be also your community health clinics. Indian health services would fall under here as well. Even community and migrant worker health centers would all fall under your ambulatory services. Outpatient clinics. So outpatient clinics can provide care to clients after hospitalization. So you can get your disease managed on an ambulatory basis, even for those that don't need to be hospitalized. They can be part of a healthcare system or they can be freestanding. So like some of your hospitals, they may have one side of the hospital is for like inpatient services, and then the other side of the hospital, they may have like outpatient services, like specialists and primary care, things like that. Most cases, you need to make an appointment in order to go. And the number and the type of the specialized clinics that they have, are usually catered to the population. So they may have, diabetes clinics, neurology, allergists, oncology. Again, it's going to depend on the needs of the people in the area. Um, our urgent care centers, like I was saying, so many down here. Those are walk-in services. Usually don't need an appointment for your urgent care centers. For a lot of people, they do replace primary care. So if you don't have a primary care provider, or maybe you're uninsured or underinsured, they may use either the urgent care centers or even emergency rooms as primary care services. But they do make primary care available as an alternative to family healthcare providers. Um, it's also a little bit more convenient, right? Especially if you work all day, your doctor's offices are only usually open during the day. But if you need after hours appointments, or even if you get sick after hours, sometimes your urgent care centers are more convenient. The name of the name of the center, it reflects the type of care that is given. So, express care, quick care, urgent care, convenience care. Um, it's kind of like, what is it? Is it the Minute Clinic, kind of like the Minute Clinic at CVS, right? You can go and get certain things done there. I don't know all the services that they offer, but I know they do immunizations. Um, but it's very similar to that as well. One day surgical centers. They perform surgery at a scheduled time and date. Then, as soon as the client or you recover from anesthesia, you're considered stable, you are discharged to home. And so surgery centers eliminate the need and monetary charge for being hospitalized overnight, right? So if you don't have to be hospitalized and you can go home that day, you don't have those charges. Services are also we do not just, there are ambulatory surgery centers that are separate from hospitals. There are hospitals also have an outpatient surgery center, which is the same thing. Instead of, you go in for your surgery, instead of spending the night, you go home for the day, or you go home after the surgery, instead of being admitted. It really just depends. Most types of surgeries can be performed in ambulatory care centers. However, they're not going to do complex surgeries. Um, so you're not going to go and have open heart surgery in an ambulatory care center, right? You're going to have that as an inpatient surgery, because you obviously are going to be admitted and need to be monitored afterwards. But some of those simpler surgeries, tonsil removal, shoulder surgeries, knees. can be done in an ambulatory care center, as long as they can be discharged that day. Free clinics. So some communities have established free or reduced fee clinics as way of also providing primary health care there for people who cannot afford traditional health services or are reluctant to use more traditional services. Your cost is based on your income, right? They also may have a age or an income limit. They are staffed by a salaried administrator, and then the other healthcare providers are usually volunteers or voluntary. And there is a volunteer board that makes policy decisions for the clinic. This too, the number of free clinics that are available are going to depend on the area that you live in, as well as the needs of the people in the community. We know that some areas, right, have much higher need for free clinics. Others may have a less need. And then it's voluntary, right? So they have to have staff that are willing to come in. What's the word I'm looking for? They have to have willing, staff that is willing to come in and provide those services. I don't know what I couldn't figure out what word I wanted to use. We have skilled nursing care. So skilled nursing care, long-term care facilities. So we offered skilled care in long-term care facilities to help people who have disabilities or chronic medical needs. The goal is to promote, maintain, or restore health or minimize the effects of illness or injury or disability. Skilled care is any medically necessary, or I'm sorry, it's care that is medically necessary to improve the quality of the client's health or to maintain or slow decompensation of a client's condition. So with skilled care services, um, they have to have a skilled need. So whether it's wound care, whether it's tube feeding, it could even be like IV antibiotics, that kind of thing. They have to have a skilled need to in order to provide that skilled nursing. Home health services differ from hospitals and long-term care, right? So we're providing care for the client at home. The client also must be considered homebound and required skilled care. Um, and so a lot of times with home health, anybody want to work home health or anybody work home health now? Yeah. Do you work it now or do you want to work it?
I worked it now, but I just quit actually because I had a latex allergy. And
Oh
the lady,
no.
she's not trying to buy new gloves, latex gloves. I'm like, okay, I can't work for you if you're not trying to buy new gloves.
Are you serious?
Yes, she's one of them.
Oh my gosh.
Yeah,
So,
I literally almost died in her living room trying to put her mom back to bed so I can go to the hospital.
oh my gosh, that's horrible. So, how do you like home health? I'm just curious.
But being in school is really flexible because it's like you get to do everything that you can do right there and then like still monitor them while doing your homework. And it's like some places that I have been prior before this lady, I almost treat them like they're my grandma or my grandpa. Like it's like that special bond. And
Hmm. So you do like the 8 hour shifts?
yeah,
So
so
almost
the
like
most I
private
did
duty?
was 12 hours. The most I did was 12 hours. But I like
So
working with Jerry patients that I've been doing working with geriatrics for like 6 years.
okay. Yeah, I love my geriatric patients. But yeah, so there's different types of home health. So like other types of home health, like you might not be there for like 8 or 12 hours. You might just go in, do a quick assessment, give medication, something along those lines. And then of course they have the ones, that need the full amount of care. So they'll do like a whole shift. So there is different. Um, I don't know. I thought about doing home health at one point in my career, One, I don't like to drive. That's my biggest issue. I don't like to drive. I don't know if I'm comfortable going into other people's houses. That's another just a
That's why
not a
I don't want to do home health. I don't want to go
It's
into.
definitely change. One time I seen someone room. I wasn't supposed to go in that room, but she never told me. And I walked in there and I saw the whole altar. Like she had the skull, candles on the floor, and I was like, yeah, this is my last day here. Yeah.
yeah.
It's very interesting.
Yeah, that's why. And I heard somebody else say it. Yeah, I don't want to go into other people's homes. I don't know. I'm just not, I guess I'm not comfortable around that with that. But I did think about it because I started off as a home health aide, but as a home health aide, I mean, I didn't go in and spend a whole lot of time. A lot of times it was just going in and checking vital signs, maybe helping to like transfer them from, the bed to the chair or something along those lines. But I didn't spend like a whole lot of time. So yeah, I can't do it. And I know people that love it. Like I know that people that love home health. Um, but yeah, so one of the big things about home health, especially, is education. And so, the teaching the client and the family self-care. The RN, of course, is going to be the case manager, but LPNs can go in also and provide services, depending on their scope of practice, right? There's wound care, there's medications, there's vital signs, there's other things that need to be done for those clients. Um, but again, with home health, we can do skilled nursing, we can do PTOT, speech therapy. Um, they sometimes will have social services, home health aides, and then, even sometimes like respiratory or nutritional services can be provided in the home. Um, Skilled nursing services, again, these are provided directed by the RNs, and then of course the LPN can provide the basic service. Lots of teaching, supervising, giving medications, even helping them to prepare their medications for self-administration. So I knew some nurses that would go like on a Sunday, and those pill boxes for the week, they would help the client like fill out the pill, fill the pill boxes for the weeks, um, administering injections, glucose testing. Um, then making sure that the environment is safe. Like I don't know if I what I would do if I saw a whole altar set up in somebody's home. That is their religious preference. I have nothing against that.
Doesn't don't
um
the Mexican culture like Day of the Dead? Don't they set stuff up like that?
mhm, mhm. Yes, I have. Yeah, I love my Day of the Dead stuff. I'm not gonna lie, I do love it. But yeah, I don't have an altar. Like I don't have an altar, but I do have my Day of the Dead stuff. Um, they can also do ostomy care, like I said, wound care. We can do bowel and bladder retraining, oxygen, respiratory care as well, IV therapy, IV therapy. So I had a pick line. I had a home health nurse. She came out, I did my own IV antibiotics, but she would come out once a week. She would draw my blood, change the dressing on my pick line, just do a quick assessment, make sure that everything looked okay. Um, And it's a lot better than, right, being it, sorry, having to go into like a skilled facility, right? We can keep them at home, where they're more comfortable. Other types of services, of course, we have community health nursing services. The goal there is to improve the health status of communities or groups through education, screening, and care outside of an acute care setting. So a lot of your community health nurses would work within the local health department, and depending on where you are and the size of your health department is going to determine the services that are provided. We have adult daycare centers. Adult daycare centers are awesome, care what anybody says. So um, adult daycare centers are for those who need supervision due to either physical or safety needs. They may have caregivers, they may live with family members, so they have care that is available in the evenings, or even on the weekends. But they're not safe to leave by them home by the home by themselves all day. And so they can go into these adult daycare centers for socialization, stimulation. They also may get assistance with some of their ADLs. They are in a nice, safe environment. Some of them even offer transportation, so they'll come and pick up the person in the morning and bring them back in the evenings. Um, Meals may be provided to. Most of the ones I've seen, they do like breakfast and lunch, but dinner is usually, when they get home with their families. Um, they supervised by either an RN or a social worker. They also may have CNAs or personal care assistants that are there as well. And then even volunteers within those. But they're great. PACE is one of them. What is it? The program for all-inclusive care of the elderly. I know some of the adult centers also have providers on staff. So depending on the center, they may actually have healthcare providers there. So if there are any needs that need to be addressed, right, they can get them addressed there as well. Independent living facilities. These are just independent living apartments. They're not licensed. They aren't regulated for healthcare delivery. So they are, they just want to basically live with other people their age. So, when we look at independent living, like your older, like your 55 plus communities, that kind of thing. Um, they may have some planned activities. They may have like buses, for shopping and things like that. Um, which is some of them I looked into this when my mom was alive. We had looked into independent living, even in assisted living, and it was way beyond what we could afford. I just was like, but she wanted to stay home, so we kept her at home, but some of them were a little bit pricey. Assisted living programs, they provide a home with services. So of course they emphasize privacy as well as choice. Um, they're like little apartments, for older adults that are trying to remain as independent as possible, but may not be able to manage all of their ADLs. Um, they usually have their own, I mean, the ones that I've seen, they look like little apartments. They have like a small living area, a little kitchen, they have private bedroom, bathroom. Um, and so they're usually always handicapped accessible as well. They do get some help with their daily routine, but not generally 24 hours. It really just depends on where, what the home offers or the complex offers, but they can get help with dressing and bathing. Um, they also offer some care management. Skilled nursing services can come in if they need like home health services as well. These are like the new ones. Now, these are some really cool things. Your continuing care retirement services, or yeah, your continuing care retirement communities. So Um, they provide a bunch of living options. So you may be in the independent living part of the complex, I guess. Um, and let's say are enjoying your independent living and you fall and you break a hip, okay? And you need to go to skilled care for a little while to get some rehab. That's all within the same community, within the same campus. So you can literally go from one part of, or what's the word I'm looking for, one level of care to another level of care, depending on their needs. So, or you could just have general, like you start off in independent living and you start to decline, you go to assisted living, decline a little bit more, and then of course you can go into, right, the long-term care setting. And it's all within the same area. There's lots of different options there. I have seen some of these are really cool. I've never looked to see how much they cost, but some of them are actually pretty interesting. They offer a lot of different services. So um, we also have our um, rehabilitation services. So rehabilitation services focus on the return of function and prevention of further disability. And there's a variety of places that rehab can be offered. They can do it in a specific rehab center. There are um, like specialty rehab facilities, which can be freestanding or they can even be part of a hospital. So one of the hospitals I know actually has 2 floors of acute rehab. So they have, an injury or they've had an extensive surgery and they need intensive therapy. They can go to the rehab part of the hospital. It can happen in long-term care facilities. So the skilled side of a long-term care facility would offer the skilled services and the rehab. There's outpatient, there's residential homes, and then there's, even at home. You can get the rehab services at home. Of course, we know nurses play a huge part of that role in that. Wellness centers. So wellness centers, um, this is promoting the huge emphasis on promoting wellness, um, and detecting diseases in early stages, right? Because we know that if we can't even talk, can't if we detect disease in the earlier stages, right, it usually has much better outcome for our clients, right? We can initiate treatment right away, with the goal, of course, to cure, right? Or at least prevent further deterioration. But wellness centers, they may have nutritional counseling, exercise programs, stress reduction, weight control. Um, and so this is more private industry versus public. But this could be something like Weight Watchers, stress control, parenting classes, um, smoking cessation classes. Um, and, a lot of times your LPNs are employed to work with the RN or even like a nurse practitioner. Um, some of your insurance companies offer health coaching as well. Um, so basically checking in on clients about their blood pressure, about whatever disease process they have, their glucose levels, answering any questions, providing any guidance, and then of course reporting back to their provider. Um, so that's another option too. Obviously, you need to have a little bit of experience in order to do that. But that is another option, especially if people like to work from home. It's calling clients and talking with patients on the phone, and then charting in their charts. And then we have hospice care. So hospice care is your end of life services. And so this is available in most areas for patients that have been certified as terminally ill. And so there's generally a prognosis of 6 months or less to live if the disease runs its normal course. Does not mean that you have to die within 6 months, because I have had patients that have been on hospice for years. Okay, even though they've had a terminal diagnosis, they have, they're still alive. Um, and they still receive their hospice service. But the philosophy of hospice care is to maintain comfort as death approaches. So it's a death with dignity approach. Um, and hospice can be provided in a bunch of different areas as well. So hospitals, long-term care facilities, they can do hospice at home. Some hospice organizations actually have a like hospice homes. So it's a home that they, bring the patient into and they provide the hospice services there. This was a new one for me. I'll tell you a story. Um, so the gentleman, the pharmacy, our delivery guy from pharmacy, um, we were talking, he was, delivering meds one evening. Um, he was telling me that I don't know which hospice agency it is down here, but they actually rent out a floor of a hotel and they provide hospice services in the hotel because he's like, I've had to, he delivers medications to the hotel. So that was new for me. I had never heard of that. I've heard of hospice homes, right? Where they have the home set up for hospice patients, never in a hotel. So I thought that was interesting. Um, I also, another thing that was interesting for me was down here, we have hospice patients that are still full codes. So even though the whole premise of hospice is death with dignity, we have clients that are full codes. So if they stop breathing, if they go into cardiac arrest, whatever it is, we have to perform CPR, which was new for me because, like I said, hospice is death with dignity, right? We're helping them through the dying process. But yes, there are hospice patients that are full codes. So that was a hard one for me. And I have to really pay attention because, somebody codes, I have to make sure that, if we have a hospice patient that's getting ready to pass, that they're not a full code, that they are, or, if they're a DNR. Go
That
ahead.
is weird because they're so fragile at that time. Like all I can think about is performing CPR on somebody that is like, sorry to say, but skinny bones. Like that's odd.
Yes. A lot. So from what I have learned, um, it's so what ends up happening, right, is the client gets sick, they get ill, they've been a full code, they appoint their family member as, you know, their power of attorney, and the family members usually are the ones that aren't ready to let go, even though they have accepted hospice services, they're not ready to make them the DNR.
Oh, now I can
Um,
see that. I can see that. Them not
yeah.
switching. Not, I thought
Uh,
it was their personal choice, but I could see a family member not switching it.
Yeah. And a lot of times it's the family. And and I'm glad that it's not me because I don't know if I could do this tactfully or not. Because my mom was in hospice care. And we had this conversation, my brother and I. But I don't know how I could tactfully tell a family member like what exactly is going to happen to their family member if I start pumping on their chest, like I don't know how to tactfully say, like, I'm probably going to break every single one of your mom's ribs, right? And I might puncture a heart, puncture a lung, puncture a liver, puncture a spleen, right? Um, and so it's
Well,
hard that,
books teach
and
us to be direct, so I mean that's the only way.
that is true. They do. And no, we do teach you guys to be direct and honest, right? Um, but yeah, that to me, it was, because we actually had a situation, where a hospice client passed away. Um, and the RN went in, the LPN went and told the RN, hey, this hospice patient just passed away. The RN, was in the middle of doing something else at the time. She goes, okay, I'll be there in a couple minutes. It was probably like 10 or 15 minutes after the lady had passed away. The RN went in and pronounced the resident. Nobody checked the chart. and the patient was a full code. So then they had to initiate a whole full code on this poor woman because she was a full code. Of course, they weren't able to bring her back. But yes. And she was, and I was talking to her after. She said it was the most horrible experience in her life. She's like, I've done CPR because she used to be an ICU nurse. She goes, I've done CPR numerous times on people. She said, but that was horrible. For her, it was, and so yes,
It's
they are
actually
usually.
cruel. It's cruel.
It is. Because they're very frail, they're very fragile, especially depending on the diagnosis. Most of them are very fragile and very frail, and doing CPR is going to cause a lot of damage. And it's not comfortable. It's not comfortable as a nurse, that you're going in and really know that what you're doing is futile. You're not going to be able to bring them back, but you have to because, right, we are required to. Um, so yeah, having those conversations with the family is super important and providing them that information. Um, but yeah, unfortunately, there wasn't any issues. The family wasn't, I mean, they were upset, of course, that their family member died, but they knew that she was gonna die. I guess they were just still not mentally prepared for her to go. So I mean, it worked out okay, but still was, yeah, it was that I just felt bad for the nurse that had to go in and do the CPR. Like she felt horrible afterwards. Um, Palliative care. So palliative care is similar to hospice, okay, but the difference with palliative care is it's comfort care that we're providing at any stage of the disease. Okay, so palliative care can be something as simple as giving IV fluids, right, to somebody that is dehydrated. Now we can give it in conjunction with hospice care, or we can just use palliative care. And with palliative care, unlike with hospice care, they've usually stopped all life-saving treatments. With your palliative care, they can still choose to receive life-saving and treatments. So that's probably the biggest difference. So not all you, not all, oh my gosh, not all palliative care is hospice, but hospice clients receive palliative care. So again, palliative care can be any stage of the illness, even if they're not terminal. Like I said, you have somebody that is extremely dehydrated. Maybe they are receiving chemotherapy and they have the nausea and the vomiting, then, diarrhea, that kind of thing. And we give them, IV fluids, right? That's a palliative treatment that we can provide. Um, so again, it helps to improve the quality of life of patients and their families by relieving symptoms and the stress of a serious or debilitating illness. Help to relieve symptoms of loss of appetite, pain, nausea, sleeplessness, even providing help with healthcare decision making, supporting family members. So again, you don't have to be terminal in order to receive palliative care. You have to have a terminal diagnosis in order to receive hospice care. I know that was a ton of information, but does anybody have any questions on chapter 15? Yes. No, no questions. All right. So chapter 16 is all about insurance and how we finance healthcare. But we'll go ahead and take a break. Be back at 4:10. All right. So last chapter. So chapter 16 again is all about financing issues and trends. So how we finance healthcare. Um, So, to start off with the U.S. healthcare system, it has been described as poorly organized and a complicated maze of services which lacks preventive care, wastes resources, and is very expensive. And anybody that has used the healthcare system in the United States, we can totally agree with that, right? Some of the prices are a little bit excessive. Um, so there's, things that have evolved over time to try to help to cut some of the costs. Um, One of them, Medicare, changed from a fee for service to what we call a prospective payment based on DRGs or diagnostic related group or diagnosis related groups. Um, so basically what that means is before we started doing that, you went into the hospital for whatever reason, say somebody had a heart attack, okay? And the insurance, what's going on with my chair? I think my chair was sinking. Um, you'd get get this huge bill from the hospital, right? Every little thing would be on there. Um, every aspirin, every Tylenol, every medication, every IV needle, like it was, they basically was a fee for service, right? So you get this itemized bill. What the diagnostic related group did was it lumped the payment, basically saying, all right, so you have a client that comes in, they're having a heart attack, and then we're going to give you a set fee, right, to treat that patient with the heart attack. And so it was a way for hospitals to really look at cost saving techniques. Um, this payment extended to include healthcare provider payment, which led to our managed care organizations. So managed care organizations are things like your HMOs, your PPOs, your POS, or point of service plans, open access plans. So a variety of different healthcare plans opened up. And so we made all these changes. However, there's still increase in costs. We know that there are still health inequities regarding healthcare access in the United States. Not all Americans have access to healthcare, right? Particularly the unemployed or underemployed. We know that the poor struggled with accessing care even despite healthcare coverage as well. So still issues that we need to work on. So we, some of the other, system changes, minimized client length of stay. Um, and so this has kind of been, what's the word I'm looking for? Controversial, I guess would be a good one. We look at minimized client length of stay. That's your utilization management. How long do they really need to stay in the hospital when, they have certain issues? Um, so this was, I'm trying to, and my daughter's older, like all my kids are older, but, um, so, I had my first child, I had a normal, delivery, stayed in the hospital for 2 days, right? Discharged. Between my son and my daughter, there's 2 years, they made this change. They said that, um, if you, or was it not my first daughter, I'm sorry, it was my second daughter. My first daughter and my second daughter are a year and 17 days apart. So it was my second daughter. They're like, you only had to stay in the hospital for 24 hours after an uncomplicated delivery, right? It didn't last very long, right? Because what ends up happening? You know, go home after that 24 hours. Does that mean that you're free and clear from postpartum hemorrhage and other postpartum complications? Absolutely not. So that did not stay in place for very long. Um, so the minute, you know, the client length of stay, sometimes even now, is something that's controversial, right? As somebody that works in skilled care, you know, as a matter of fact, the other day, this was last week, we had a client that was discharged from the hospital, brought in for skilled care, and literally coded once we got them on the bed, went in the facility. They were not stable when they left the hospital. They should have been still stayed in the hospital. Um, so again, still, you know, have some issues with length of stay. Healthcare costs only improved minimally, still have a huge way to go with that. We talked about the inequities, and of course, not all have access to healthcare, so they're not getting those preventative services. So we had our Healthcare Reform Act, the ACA. This was, you know, initially referred to as Obamacare because it was signed into law by President Obama. Um, and it was the first wide sweeping piece of legislation to address healthcare reform since 1965. And so pretty significant amount of time. And that was when Medicare was added to the Social Security Act. So the program was designed to enhance the access and affordability of healthcare, right? Particularly to those that are in that were in financial need in the United States. It has decreased the amount of uninsured in the United States. We still have a ways to go. There are still plenty of people that are uninsured and underinsured in the United States. It also eliminated lifetime coverage limits. It reduced prescription costs for Medicare beneficiaries. And it also um, ensured that pre-existing conditions are covered. So the law prohibits insurance companies from denying coverage if you have a pre-existing condition. And this was a huge issue. So my cousin, she is a type 1 diabetic. And so this was a while ago, but she had to, you know, she got a new job, she had to change insurances, and the when she went to change her insurance because she's been a type 1 diabetic since she was 6 months old. They had a lockout period. So she literally had no health insurance because of her pre-existing conditions. And that's, you know, not just my cousin, that was a lot of people have just, you know, chronic diseases. And they were being either denied coverage um, or they were being, I forget what it's called. Basically, you had like a waiting period before you could use your insurance. So we look at financing of healthcare costs. The two most common ways that we finance are fee for service and capitation. So fee for service, that was the traditional method of paying healthcare. And so your healthcare providers are paid a fee for each service they provide. So you go in, let's say you have strep throat, right? You get examined by the doctor, you get your throat culture, and then the physician bills for those services. And so physicians were directly reimbursed for most order diagnostic tests and treatments for illness. Some insurance companies don't reimburse for preventative or diagnostic tests for early stage illness, which we know that's a issue, right? Because the earlier we diagnose, right, the better outcome we have. Capitation involves healthcare providers receiving a fee per member over a designated time frame. So there is a monthly fee that's charged by the provider for each member of the insurance group for a specific set of services. And so if healthcare services cost more than what the monthly fee is, then the provider absorbs the cost. But you also have services that are going to cost less than the monthly fee. So that ends up being a profit, right, for that healthcare provider. I always think of this as like your car insurance. Okay. Pay your car insurance every month, right? Most people don't use their car insurance that often, right? You usually only have to use your car insurance, if there's an accident or damage to your car that's covered, right? And so the insurance company, that's profit for them, right? Because they're getting your monthly premium, but you're not using it. Same like your homeowner's insurance or your renter's insurance, right? We pay these fees every month. And really, I mean, we hope that we never have to use them, right? But that's all profit um, for the insurance company, right? And that also allows when somebody else uses, their insurance maybe more often, right? Then they have that money available. That's how I think of capitation. Um, we also have how clients pay for health insurance. So personal payment or private pay, this was payment directly by the client, right? That used to be the primary way that people paid for healthcare services before the 1940s, right? You got sick, you went to the doctor said, okay, it'll be $10 for whatever I just did. Here's your money, have a nice day. Um, Healthcare process now, generally we don't have a whole lot of people that are going to pay for their healthcare services out of pocket, right? Just because of the expense. So we have health insurance, right? So private health insurance, it pools those individual contributions for a common group goal, right? Which is protection from financial disaster as a result of healthcare bills, right? So you get your health insurance, whether it's Blue Cross Blue Shield, whether it's United Healthcare, Aetna. I mean, there's more out there. Those are just the ones that come off the top of my head, right? And it's kind of similar too, right? You pay your healthcare premiums every month. And some people use the doctor more often than others. Generally, if you have a family, you're going to go to the doctor more often. The Affordable Care Act, doesn't require all employers to provide health benefits, but it does impose penalties on larger employees that have 50 employees or more that don't provide insurance to their workers, okay, or that they provide coverage that is unaffordable. So what that means is if a company has more than 50 employees, they're required to offer health insurance to their employees that is affordable. All right. So they're not always going to just go with, the cheapest plan for them, which is going to be the more money for the employees. So it has to be affordable. Small businesses, less than 50 people, they will get a tax credit if they do offer health insurance. Okay. So it's a big push. Private or individual health insurance. So, if you're not employed, or maybe you work for a smaller company that doesn't offer health insurance. Some of your health insurance companies will offer individual plans. Premiums for those plans are based on your health risk and your age, as well as tobacco usage. So there are the individual health insurance plans as well. So some of the terms, and I don't know how many people have their own health insurance or have ever had to really look at health insurance. But as you're getting ready to graduate, start working, and you have to choose your health insurance benefits, make sure you understand these terms because they are super important. Premium is the monthly fee that you pay for your healthcare insurance. Okay, so you go work for X hospital. Most organizations, not all, but most will offer a couple different options. All right. So you may have a higher option and a lower option depending. But that's how much you're going to pay out of pocket. So they're going to take that right out of your paycheck. Most of the time in most companies, that monthly fee is taken out. Like if you get paid every 2 weeks, they're going to take a portion out every 2 weeks. But that premium is something to really look at. Your deductible is something you want to look at as well. The deductible is the yearly amount that you must spend out of pocket for healthcare services before your health insurance will begin to pay. So you may like look at the premium and go, oh my goodness, my premium is only 200, maybe it's 400 a month, so it's 200 every 2 weeks. But if that deductible is $10,000, you're really not saving any money because that's more money out of your pocket, right? So you really have to look at the terms of your insurance that you're choosing. Copay is how much you pay at the time of an office visit, picking up your prescription, or even before a hospital service, right? So you may have like let's say a $30 copay to go to your primary care provider, and then maybe a $50 copay to use a specialist or use the emergency room. There's different copays generally across the board. And then coinsurance is once you have met your deductible, okay, the coinsurance is how much of the total bill that you have to pay. And then so maybe it's like a 80/20. The insurance is going to pay 80% of it, and then you're going to pay 20%. So sorry. Um, so when you're looking at choosing your insurance, if you've never had to do this before, pay really close attention to the numbers. Okay. And then generally speaking, it's going to be a different cost, whether it's an individual plan or a family plan. I will tell you, health insurance or your medical insurance is going to be your most expensive cost. Dental insurance, vision insurance, those are generally very inexpensive. It's your health insurance that generally costs more. Why? It's crazy. So public health insurance. So public health insurance, this is going to include your Medicare, your Medicaid, and your Veterans Health Administration. So give me 1 second, I apologize. I don't understand that. Okay. So Medicare. So in 1965, Medicare was added to the Social Security Act. And it is a federally sponsored entitlement program as well as a public health insurance plan. It helps to finance healthcare for all persons over the age of 65 and their spouses who have at least a 10-year record in Medicare covered employment and are a citizen or permanent resident of the United States. So what that means is, for one, you have to be a citizen or a permanent resident, and you've had to pay Medicare taxes for at least 10 years. And you are automatically eligible at that point for Medicare once you turn age 65. Coverage was also given to certain younger persons with disabilities and those that have end-stage renal disease. Okay, so if you're younger than 65 and you have a disability or you have end-stage renal disease, then you would qualify for Medicare as well. No person is denied coverage based on past medical history. Again, this is a federally sponsored entitlement program that as long as you meet the requirements, you are eligible regardless of your health status once you turn 65. There are different parts to Medicare. All right. So when we look at Medicare, Medicare Part A is your hospital insurance for inpatient hospital care. All right. So this is available without cost. Again, it's funded by our payroll taxes. It does include a deductible and a co-insurance that starts on day 61 of hospitalization. So not horrible. So inpatient hospital care, so meals, meds, supplies, labs, radiology tests, even if you have to go into the ICU. It also covers your post-hospitalization skilled nursing facility for the first 20 days. And then the rest of the 100 days, it would require a co-insurance. In some cases, home health services will also be covered. Um, your Medicare Part B um, is similar to like, I don't know, United Healthcare, Blue Cross Blue Shield. All right, it's your major medical insurance. It is funded by monthly premiums that are income related. Okay, so you only qualify for Medicare Part A when you turn 65, you have to pay for Part B. All right, so there is a standard monthly premium that has to pay, but again, it is, income related. Your premiums are income related. So Part B covers your healthcare provider office visits, right? Your general well checks, your outpatient hospital services. So if you have to use the emergency room, it also covers mental health services, labs, x-rays or diagnostic tests, ambulance transportation, DME, some of your diabetic supplies. Um, it also will cover PT, OT, and speech therapy, as well as preventive services. Again, Part B is not going to cover your prescription plans or any of those kinds of things, which brings us to Medicare Part C. So Medicare Part C is your Medicare Advantage plans. These are offered by a private company that contracts with Medicare. And towards the end of the year, usually, I mean, I feel like sometimes they start even as early as October, but it could be just me imagining things. But I want to say the Medicare open enrollment is like the first part of December. So you'll start to hear about these Medicare Advantage plans, the advertisements on TV. This is what they are. They are private companies that contract with Medicare. So it can be like United Healthcare, it can be Blue Cross Blue Shield, it can be any one of those other companies. They also offer prescription coverage along with other coverages. And then Medicare Part D. Hold on one second. Somebody is coming in. Oh, Janika, did you get kicked out or are you switching?
Yeah, I need to switch my device.
Okay. Medicare Part D is our prescription drug coverage. And so this is offered again by insurance companies and other private Medicare approved companies. Again, it's an additional cost that is out of pocket for our Medicare recipients. There's also Medicare supplemental insurance or what we call Medigap insurance, because of the items that Medicare doesn't cover. A lot of people are encouraged to pay or to buy supplemental insurance in addition to Medicare. It helps to cover copays, deductibles, the co-insurances, things that basically Medicare does not cover. And it's really specific. Like you can't enroll in both C and D. If you have a Medicare Advantage plan that includes prescription drug coverage, then you can't join the Part D plan. Yeah, there's lots of different rules that kind of fall with Medicare. I feel sorry for some of the people trying to navigate some of this because it can be very difficult. Then we have Medicaid. Um, Medicaid was added to the Social Security Act in 1965 as well. It provides medical assistance for eligible families and individuals with low income and resources. So you have to meet the eligibility requirements. It is a cooperative venture. It's jointly funded by federal and state governments. So what that means is the federal government does establish pretty broad national guidelines for Medicaid, but each state runs its own programs. All right. And it also lists its own requirements as well as eligibility. So if you're eligible for Medicaid in one state, you may not be eligible for Medicaid in another. So if you have Medicaid, let's say you live in New Jersey, um, and you're eligible for Medicaid in New Jersey and you move to, I don't know, Massachusetts. Um, All right, you may not be eligible for Medicaid in Massachusetts, okay, because each state has its own eligibility. Undocumented immigrants and legal immigrants who have not resided in the US for 5 years are not eligible. All right, so basically that means you have to have been here for at least 5 years in order to be eligible for Medicaid. We also have CHIP, which is your, hold on. Okay. Is your children's health insurance program. This is a program under Medicaid as well. This offers medical assistance for eligible children. It covers uninsured children up to the income guidelines. So again, there's income guidelines, for CHIP, but it does provide free or low cost health insurance for children up to age 19. And when I worked in peds, I had a lot of my patients were on CHIP, and it actually was a really good program. There was like no out-of-pocket costs for a lot of my patients, a lot of their parents, and it provided all of the services that they needed. So we look at the cost of healthcare, and we talked about some of the costs, right? Your premiums, your co-insurances, your deductibles. And so the continual rise in costs have resulted in annual increases in health insurance premiums. And I see, you'll see that more so when you do like your open enrollment every year and have to re-sign up for your insurance. You'll see that a lot of times the premiums are going up for employers. The premiums go up for employers, then generally the cost of health insurance is going to go up for the consumers as well. The Affordable Care Act, though, does require the government to create a process in conjunction with the states where insurers have to justify any unreasonable premium increase. All right, so I mean, there, I guess, would consider a reasonable, I don't know what they consider a reasonable increase is, but if it's unreasonable, they have to justify why they're increasing their costs so much. Are uninsured, okay. Um, the uninsured often includes our low-wage employees, right? This group of people, they are employed in low-wage jobs that are less likely to offer insurance benefits. Your middle class, some of these workers are also unemployed. Those that are employed may be priced out of the care insurance market by rapidly rising healthcare insurance premiums. So let's use this as an example. So let's say you're making, I'm just going to use $10 an hour so I don't have to do a whole lot of math in my head, okay? So if I make $10 an hour, okay, and I work a 40-hour week, that's $400 a week, okay? Which is what, $1,600 a month, okay? If my insurance is $200 every 2 weeks, that's 400, that leaves $1,200. And of course, that's pre-tax, right? So you're not really bringing home 1,600. Depending on your tax status, you may only bring home, 1,100 or, sometimes less. And you're, taking $400 out of that for your health insurance, right? That leaves you what, $600 for the month, right? Which is, not, most people are not going to be able to live on $600 a month, right? Especially if you're single, right? You don't have anybody else helping you pay your bills. All right. So again, they might be priced out of those health insurance premiums just because they don't make enough money, right, to sustain their homes and pay for health insurance. So as a result of the Affordable Care Act, again, everybody was required to obtain health insurance or pay a penalty, right? And that was a big, source of contention. Um, in some cases, and I'm, just talking with other people, when this occurred, the penalty was cheaper than sometimes the insurance. So they said they can't deny you, right, because of pre-existing conditions. So I had a friend who, back in high school, had, I forget what kind of cancer he had, but he had cancer in high school, got treated, He was deemed cured, hasn't had a relapse, nothing since. Um, he lost his job, lost his full-time job. So he was working two part-time jobs and, couldn't get health insurance with either one of the part-time jobs. But because of this law, right, he had to go through and get insurance. And because of his past medical history, the premiums that they couldn't deny him, but the premiums they wanted to charge were $900 a month. 900, almost $1,000 a month, to get health insurance, working two part-time jobs, right? He's like, there's no way that he could afford the $900 a month. So he just chose to pay the penalty, right, when it came to the tax. Back in 2017, they passed the law, they passed the tax bill, that eliminated the penalty as of 2019. So, they don't have to pay the penalty anymore if you don't have health insurance. Um, but that was a big issue. Um, Emergency room treatment is expensive. We know, the goal of emergency room, right, is to treat, ill or injured people, generally not for less serious illnesses, but with the number of uninsured population out there, we do have quite a few people, quite a few thousand numbers people, that use the emergency rooms, right, as a source of primary care because they don't have any other access. So, some of the alternatives to pay if they qualify for Medicaid, private pay if they can afford it. Charity care is another option if you can find charity care. Not a lot of charity care, but there is some out there. It used to be too that medical bills would not populate on your tax, what is not tax, your credit report. That has since changed, right? So if you don't pay your medical bills, it's going to get reported to, whichever one of those reporting agencies. Um, and we know if we don't have access to healthcare, right, they're not getting preventive care, right? They are only seeking treatment when a health problem occurs, and that results in delayed care. And so they're being diagnosed with issues in later stages, which is going to end up costing more, right? If we find a cancer at a stage 4, it's going to cost more to treat. It's going to be harder to treat, right, than if we found it at a stage 1, right? So if we don't have it, then, if we don't have the insurance, we don't have the access, then we're not getting that preventative care and that, those really, those screenings that we should be getting. So the prospective payment system, and I touched on this a little bit at the beginning when we were talking about like the DRGs and things like that. But PPS, or the prospective payment system, is our system of reimbursement that pays a predetermined fixed amount per patient admission, regardless of the actual cost to provide that care. And again, right, that's that diagnostic related group or diagnosis related group. So like I said, patient comes in, they're having a heart attack. Maybe they have, the agreement with the insurance company is okay, we have this patient that's had a heart attack, and we're going to give you the set fee is going to be, $30,000, whatever the set fee is. Okay. The hospital knows exactly what they're going to get for each type of admission. Okay. This is a predetermined set it's a predetermined set of reimbursement. All right. So the government announces to the hospital in advance what it'll pay for healthcare costs. Right. So they know exactly how much they are going to get. So the goal of this was to give them some, an incentive to control input costs and resource use, right? Your cost containment. However, like I was saying earlier, it has been criticized as promoting abbreviated hospital stays and services, leading to reduced quality of care and a higher rate of readmissions. Okay, so, but let's say you're getting the hospital is getting that 30,000 or $50,000, whatever I said, for that patient that just had a heart attack. And maybe they were able to, cost contain that and they only maybe spent $30,000 on that person's care, right? Then that's a profit to the hospital. Could be the opposite as well. Getting $50,000 for this client and, they spent, $60,000 on providing their care, right? So that's a loss of $10,000. So it's really, when you look at it, it's why a lot of hospitals are really big on cost containment, and resource use. So that's your DRG. That's your, and it was an attempt to stop the skyrocketing costs of healthcare. And so, like I said, the hospitals are going to know what the set amount that they are going to get, as a result of that diagnosis related group. And the fee depends on, why they were hospitalized. So if they had a heart attack, if they had, I don't know if they're having, knee replacement, a hip replacement, whatever the reason, pneumonia. Okay. So they get a flat fee for each of the DRG categories, regardless of how long they stay in the hospital, right? So the incentive is to treat them and discharge them as quickly as possible. Which this part right here, discharging them as quickly as possible. Sometimes it isn't always, in the best interest of the client. Which brings us to quality, and safety and cost of healthcare some more. So anybody that's been to the doctor or has seen their hospital bills or seen a doctor bill, it's crazy, how much money we spend as consumers for healthcare, in the US. And in some cases, even with insurance, it could be extremely expensive. Um, some of the reasons why healthcare costs have gone up, um, prescription medications are ridiculously high. Um,
Spend all of that time alone in a cell half the size of this room. A call will be made to
the medical malpractice. So when I worked in peds, now I worked in peds a long time ago, so it's been quite a few years. My provider's malpractice insurance was $100,000 a year. So that's $100,000 that he had to pay out of pocket for malpractice insurance. Okay. And that malpractice insurance is there if they ever get sued for malpractice. Um, the medical technology, your CT scans, your PET scans, your MRIs, the robots and all that other stuff, right? They're extremely expensive. So that's some of the reasons why healthcare costs have gone up. The sad part about it, and this to me is almost mind-blowing, as much money as we spend on healthcare, and even with all of the technology that we have a lower life expectancy and a higher infant and maternal mortality than many of the other industrial countries in the world, right? I just don't understand. We have all these resources, but we have a lower life expectancy and a higher morbidity, mortality for our infants and our moms. So the Institute of Medicine, um, the IOM, um, it back in 1999, it did a study. And so the study was, to err as human. It was to err as humans, always the one part of it that I remember. There's more to the title, but that's what I remind it. That's what I remember about it. But the report found that up to 98,000 people die each year from preventable medical errors. 98,000 people die every year because of preventable medical errors in the United States. This wasn't a worldwide thing. This was in the United States. And it wasn't just medication errors, it was, surgical issues, some of your wrong site surgeries. So it's combination of everything. They did a follow-up study, and I always forget. I don't remember if it was 10 or 20 years later, but they did a follow-up study. One of the things they did in the initial study too was they recognized that processes was one of the biggest issues. So they even, recommended some changes, right, to help improve safety. So like your surgery timeouts. So when a patient is brought into surgery, they do a timeout, they verify provider, verify patient, the type of surgery that's going to be performed. Nurses, we have our, rights and medication administration. We have our 3 checks. What else? They did um, if you look, and I don't know if they still have it there because it's been probably about 3 years since I've actually been in a hospital. Um, but they did like caution tape around the Pyxis machines, right, in the hospitals, which if the nurse was in front of the Pyxis machine pulling their medications and they were inside that yellow line, right, nobody should talk to them or bother them, right, to reduce the risk of errors when pulling medications. So they did a variety. There were some interventions. There's more, but those are the ones that I can remember. Um, and they, like I said, they did a study. It was like 10 or 20 years later, and there was not a significant change in the amount of medical errors. So it's always going to be something that we need to focus on in improving the quality of care for our clients. So, improving quality, CQI. So, continuous quality improvement. So continuous quality improvement, you may be asked to sit on CQI committee. What they do is they look at incidences of harms or mistakes after they have occurred, okay? And then why did it occur, right? How could we prevent it from occurring again? So checklists, these are something that are really good at helping to ensure quality and safety when giving care. Just like you have a checklist, right? When you are demonstrating skills or performing skills, right? You have a checklist that you should follow, right? So that helps you, to remember how to perform that procedure, right? Um, we have the aims of the IOM, which is the Institute of Medicine for improving quality in healthcare. The 6 aims of the IOM to increase quality in healthcare is your STEEP, STEEP, safe, timely, effective, efficient, equitable, and uh, patient-centered. Sorry, couldn't remember what the P stood for. Um, And then we have continued competency in continuing education. And so one of the biggest and component of quality health is that we are able to demonstrate competency. All right. And so, as you graduate and pass your NCLEX, current nursing licensure considers nurses from all levels of educational preparation minimally competent. All right, after receive or when you get that initial license. So you have to continue, show continued competence throughout your career. So always make sure that you're keeping up on your skills, you're keeping up on evidence-based practice, that you are completing your continuing education credits prior to your licensure renewal. Other things we have Joint Commission, National Safety Patient Goals. These I know you should have heard of. Of course, it goes right down to our nursing ethics, right? Do no harm. And so again, it started from that IOM study back in 1999. So we, look at those national patient safety goals. If you've not looked at the national patient safety goals, They are different for, there are overarching goals, and then they even break them down into like specific areas. So, like your hospitals, two patient identifiers, right? When you go in to give your medications to your patients, name and date of birth, right? Using SBAR to improve staff communication, making sure we're using alarms safely. Alarm fatigue is real. When you start working, you got alarms going off all the time, right? You start to tune them out, right? We have to pay attention to those alarms. Preventing infection, right? Your central line infections, your catheter associated UTIs, identifying client safety risks. Fall prevention is always going to be a big one, and preventing mistakes in surgery. So those are just some of the ones for your hospitals. They're going to be different for long-term care. They may be different, in different areas or different aspects of nursing. But those national patient safety goals are really important. Your National Patient Safety Foundation, okay, this was created for client safety as well. It focused on building systems of safety across the continuum of care. So, you know, um, those errors of omission, errors of commission. They also provide some other things. Your transition to practice. This to me is an amazing idea and I love it. And I really wish more organizations would implement this. But the NCSBN, which is your National Council for the State Board of Nursing, they this was an initiative brought by them to improve quality and safety of healthcare by new grads. And so it's a transition to work program. And so it is like a 9 to 12 month program to aid in new nurses transitioning into clinical practice. And so a lot of times this replaced like your residency. Some hospitals still use residency programs, but this transition to practice model is really, really good. You can look at it. I think it's on the NCSBN website. Again, not many hospitals use it. More I think, are starting to implement it. I noticed that down here in this area, we have a bunch of different hospital groups. HCA, a lot of people know who HCA is. They have a transition to practice model that is utilized down here only because I've seen it I think it's on the what do you call it, LinkedIn, where they've talked about it. But it's a really good model to help, transition new nurses into the workforce. We look at improving the cost of healthcare. One of the biggest things is cost containment. Talked about, right, those DRGs. The hospital is only going to get reimbursed a certain amount of money, right, to care for your clients, right? So we have to be really careful with our cost containment. So like, following our, facility policy for charging clients for supplies, documenting care for reimbursement. Remember, if it wasn't documented, it's not done. If you're providing maximum assist for your clients, you're feeding your clients, you're doing a lot more for your clients, then you need to document that because that means that they need a higher level of care. Be efficient and effective in delivering clear care. Do it right the first time. If you have to go back and redo it, that's not efficient. It's even when let's say you have to go into the room and provide wound care, right? Just bringing what you need into that room to do that wound care. You don't want to grab the whole package of 4x4s and, you know, 20 sterile gloves and, 2 bottles of saline. You really just want to bring in the supplies that you need to do that. Once you bring supplies into a client's room, you can't bring them back out. They're only for use for that client. So that either one, it can increase the cost to the client. Two, it also is a waste of resources. So be really careful with that. Making sure that you're providing that client-centered care, right? You're building that therapeutic relationship with your client. Um, And you want to make sure that you're providing quality of care, not just quantity of care, right? You can be in and out of your client's room 20 times a day, but if they don't feel like they're receiving that quality of care, right, then that's going to be an issue. Oops. Um, all right, and so-called payment methods, penalties. So this is something that is a little bit newer too. This is the pay for performance, and I don't know if anybody has ever heard of pay for performance before. But P4P rewards hospitals for meeting and exceeding standards of care for a variety of diseases. Your diabetes, your MIs, your pneumonias, your heart failure patients. Um, and so again, this is about the quality of care, right? So if you have a client that comes in and they develop a pressure area or they get a central line infection or a catheter associated UTI, that is not providing quality of care. And your hospital, your organization is not going to get reimbursed for the care of that urinary tract or that urinary tract infection, that central line infection, that pressure area, because it could be preventable. And never events as well. Never events are seriously and highly preventable events. That's why you're not getting reimbursed because they are preventable events. If your patient gets up out of bed, after hitting the call bell because they need to use the bathroom, and you ignored the call bell and you ignored the bed alarm and they fall and they break a hip, that's a never event. And so hospital, again, it's not going to get reimbursed for those never events. So again, we have to really make sure that we're providing a safe environment, and that we're building that relationship with our clients. Other quality improvements, readmission reduction. So we talked about how, there's a push to, really discharge them, as soon as possible, right? Not keeping them in the hospital for extended periods of time. But readmission results in reduced payment when clients are readmitted to an acute care hospital within 30 days of discharge. So let's say you had that heart attack patient. Maybe let's say well, I got one better. Let's say we had a patient that came in and had to have a um, coronary artery bypass. Okay, so had a cabbage done. We discharged them. They were medically stable. We discharged them, but then in 3 weeks later, they come back to the hospital because they have an infection in their surgical site. So that would be a readmission within 30 days, and the hospital is not going to get full reimbursement from that admission. Um, So again, your acute MIs, heart failure, pneumonia, COPD, total knee, hip, cabbage surgery. So again, if something happens as a result of that cabbage and they get readmitted within 30 days, they're going to get a lower rate on their payments. Again, it's improving the transitions in care. So you as an LPN working in the hospital, right? You're going to, have a critical role in assessing your patients and recognizing any early complications, to try to prevent that readmission. Um, and this is even, I mean, honestly, this is even when, they discharge them and they go into a long-term care facility, and something happens at the long-term care facility within that first 30 days. They're not stable when they get there, and we have to send them back to the hospital. Um, so this has always been an issue. I don't think, as long as I've been a nurse, it's been an issue. Rehospitalization rates have always been a significant, source of contention. So talked about STEEP already. So S is safe. Avoid injuries to clients from the care that is intended to help them, right? So again, making sure you're doing it right, you're doing it correctly the first time, you're following your rights of medication administration, right? That we're doing procedures correctly, that it's timely, reduce weight, and sometimes harmful delays for both those who receive and those who give care. First E is effective, provide services based on scientific knowledge to all who can benefit and refrain from providing services to those who not likely to benefit. Efficient, avoid waste of equipment, supplies, ideas, and energy. Equitable, provide care that does not vary in quality because of personal characteristics such as gender, ethnicity, and socioeconomic status. And then P is your patient-centered, providing care that is respectful and responsive to individual client preferences, needs, and values. Um, More improving safety. We talked about the national patient safety goals, um, the transition to practice model. Um, Again, talked about the national patient safety goals already. Long-term care, I didn't talk about these. Talked about the hospital ones, but the long-term care national patient safety goals, it's still improving the accuracy of resident identification. And I don't know if anybody, I know you guys have done clinicals in long-term care. Sometimes identifying clients in long-term care is a little bit more difficult, okay? We don't have the nice little scanners and armbands that you see in the hospitals. If they had armbands, they may have had armbands at the beginning, but may not have armbands anymore. So one thing that with the introduction of electronic medical records, that has improved a lot, because we put pictures now, right? We put pictures in the EMR. So when the nurses are passing meds, if they don't know who a person is, they can look at the picture. The most important part of that is, if you're working with dementia patients, they may not know their date of birth, right? So having that picture is really important. Some of them, most of them still know their name. Um, there was something else I wanted to say. The important thing with this is updating the pictures every so often. When they first get admitted to a long-term care, depending on what they're there for, if they decline, okay, their facial features change, their hair changes. So updating the picture every once in a while is always helpful. Improve the safety of using medications. Okay, so this could be making sure that you're following your 9 rights, you're doing your 3 checks, that we're providing for accurate medication reconciliation. We're still worried about reducing the risk of healthcare associated infections. We use Foley catheters, we use PICC lines and central lines in long-term care and skilled care, right? So reducing the risk of those. Wound infections is another big one. So recently we had one who had developed I don't remember where the wound is now. It wasn't on her bottom. I think it was on her heel. Anyway, developed a pressure area. Wound care nurse was not treating it appropriately. Ended up developing a stage 4, and got osteomyelitis from it. Had a wound vac, had a PICC line, IV antibiotics, whole 9 yards. So healthcare associated infections can occur anywhere. Reduce the risk of resident harm resulting from falls. This is a big one, in long-term care because we don't have all of the safety things that people have in the hospitals, like bed rails and bed alarms. So we often have to get a little bit more creative, with our fall prevention. And then, of course, preventing healthcare associated pressure ulcers, making sure that your clients are turned in repositions, that they are well hydrated, that they are clean, that they are well nourished, right? That they're getting the nutrients that they need for proper wound healing. We talked about the hospital ones. We talked about your role. Um, so restructuring of the healthcare system. So, some of this has been going on for a while. And so the goal here is to improve healthcare delivery, increase quality and safety, decrease costs of care. So this is, when we look at restructuring the healthcare system, it's changes in the delivery of healthcare in the community. So we have alliances or partnerships that are formed among hospitals, clinics, labs, healthcare systems, healthcare providers. So by joining together, they coordinate the delivery of care and contain costs among providers of healthcare services, right? So, this is something as simple as buying supplies in bulk, versus, you know, um, in small amounts more often. Um, just in, little things, using your electronic medical records. Um, Consolidated systems, are also found. Mergers and acquisitions are becoming commonplace too. So you may find that some of your larger healthcare systems, like HCA, is a huge one. Mostly trying to think, it's mostly south, I think. I don't know about the northern hospitals too much, but I know HCA is in Virginia all the way down to Florida. Like I said, we have HCA here, down in Texas. And so a lot of the larger healthcare systems will start buying up some of these smaller, hospital systems. And so the larger system has a greater power to negotiate with insurance companies for reimbursements. They also can share, money, technology, right? So, like, for example, you've got, let's say, 10 hospitals in this healthcare system, right? And 8 out of the 10 hospitals are like really doing great. And you have two that are struggling, right? So the organization can take some of the resources from the ones that are doing really well and put it into the ones that are not doing so well, right? So that does help, across the board, with some of those larger systems. And then dealing with change. So, if you've not had, I'm going to stop sharing. If you've not had any experience in healthcare before now, okay, you may not, be aware of all of the changes that take place, but healthcare is constantly changing, it's constantly evolving. What you do today, you may not do tomorrow. So you're going to see change. That is one thing that you need to be prepared for is change. And so how you react to change, is, something that you need to like really look at. Are you, someone that, accepts change really well? I personally like change. I don't know why. I don't like stagnation. I like things to change. Keeps me on my toes, right? It gives me, so it makes it less mundane. But you can be a victim, a survivor, or a navigator of change. Okay, so when change happens, how do you see yourself? Victims look at change in a negative way. They fear the worst will happen. They feel helpless. They aren't going to participate in the change process. And they allow the change to control them. Survivors, they resist change but go along for the ride. They claim the change will never work. And if their prediction comes true, they're the ones to say, I told you so. And then the navigators, okay? Navigators feel in control of the situation. They feel confident and excited about the possibility of being part of the solution. Um, and they believe that they have some control, over change rather than being controlled by the change, right? So just be aware. Change is going to happen. Um, We may not always like the change that is happening, all right, but just it is inevitable. It's something that is going to happen regardless of how we feel about it. And so how you plan for change. So you can present yourselves, as invaluable, right, to your healthcare agency. Be self-directed, be motivated, be a problem solver, right? Avoid being known as the one who always asks what needs to be done next, right? So try to learn how to anticipate, and that's going to come with time. It's not always going to be, when you first start nursing, you're going to, have to learn how your organization works. But look out, try to look ahead what, you're going to do one task, what's going to happen next. Um, so identify what needs to be done, prioritize, do it, collaborate if you need to collaborate, respond flexibly to changes that are presented. And I know sometimes that's hard, but try to be as flexible, be a team player, identify tasks or protocols that can be done more efficiently. Right. This is where learning about that evidence-based practice, doing research is really important, right? You may be able to identify things that could be done better. Use your critical thinking skills. All right. And be a role model. And I know that sounds kind of cheesy, but be a role model. So in your nursing courses, in your nursing school experience, right, in your clinicals, um, you have come across nurses that are really excited to work with nursing students, and you've probably come across nurses that have nothing, they want nothing to do with nursing students. You get to be the nurse that you want to be. When you graduate and you pass your NCLEX, you get to choose what kind of nurse that you want to be. You can remember your experiences with nursing school and those good and those bad nurses. I don't want to say bad nurses, but lack of a better word. The nurses that wanted to work with students and the ones that didn't want to work with students, and you get to choose. Do you want to help the next set of students become nurses? I look at it this way. One of the big things that I love about nursing education is I'm getting older, okay? And I'm going to need nurses to take care of me if I ever have to go into the hospital. And I've been in that situation. I had a really scary health situation a few years ago, and I was in a hospital in Virginia. Um, where I would say 90% of the nurses that worked that unit were my grads. And it was from a different school. It was before I started working at Fortis. And so I got some great care. I don't know if it's because, they liked me or if it was because, they were like, we're just going to show her how great nurses are. And they had some really great care. Even when, like I said earlier, when I had to have the home health nurse, when I was same sickness, um, all of my home health nurses that I had were all prior grads of mine as well. So it's great to watch you guys go graduate and go out and practice nursing. And so, that's the way I look at it. That's why when I was on the, even now, if I'm on the floor and there's a student or a new nurse, I'm like, come on, let's go learn some stuff. Because we have to teach the new generation of nurses, right? Otherwise, what's going to happen? Um, that's just my 2 cents. But you guys, like I said, you guys have the ability to go out and be whatever type of nurse that you want to be. Um, I love it. I love it. I have a nurse now that I work with. And I feel kind of bad for him. He's a LVN. He graduated with his RN. He has taken the NCLEX. I think he said he's taken it 3 times. Um, and so now when we have downtime, we study for NCLEX together. Because I'm like, no, you need to pass. He's really smart and he is a good nurse. And I'm like, so I bring stuff with me to work. I have I have my NCLEX book. I have like a little study guide for like pharmacology. So like I'll bring things to work so that I can help him study, right? The goal is we have to nurture each other. And I know that sounds crazy, and not all nurses think like I do. But I wouldn't be in education if I didn't like what I'm doing. And I didn't enjoy teaching. I also enjoy being a nurse. So I get the both, kind of get the best of both worlds. But with all that being said, I know I'm probably rambling at this point, but you get to choose the type of nurse that you want to be. And even now, as you're getting ready to graduate, you've got a lot coming up, right? You've got to, exit HESIs, you've got, to finish out your classes, and then you've got to take your NCLEX and you've got to pass your NCLEX before you can go out into the world of nursing. And I will let you know straight up if you guys need help in preparing for NCLEX, reach out. I have no problem helping with NCLEX prep. If you don't have anybody else to help, reach out to me. I have no problem helping. I love it personally. And my son just passed his NCLEX, so I just wanted to let you know. Yes. So yeah, thank you. So I had to keep my foot in his tail, to get him to pass that NCLEX, not gonna lie. Because boys are a different breed. So boys are a different breed. My girls didn't have any issues with it. They went, they studied, they took their NCLEX, no big thing. Like he graduated in October. He just took his NCLEX. Like, come on, dude. Like, let's go. But yes, but thank you. Congrats is awesome. And I don't mean that to toot my horn. I'm very proud of my kids, 3 nurses. But yes, so if there is anything that you guys need as far as help, just let me know. Feel free to reach out. I'm here for you guys. It's what I love to do. Like I said, I love to teach. So that is my goal. But with that being said, don't forget, so next week is exam 3. The exam review is Sunday night. I'm sure Dr. Tenzo will post a Kahoots. I don't think she has yet. And then week 11, there after exam 3, sorry, we'll do our HESI review. Week 11, your attendance is going to be your HESI, so you do not have to log in on that Friday. You will have your last set of NCLEX questions that are due in week 11. And then week 12 by Monday at midnight, which off the top of my head, I don't know that date. Hold on. So we're in week 10, 11. By the 16th at midnight is when your remediation is due. So make sure that even if you get a 900, remember you still have to do that 1 hour. I will post the remediation times in the announcements, and then we will meet on week 12. Check in. Please do your course evaluations. Liked it, loved it, hated it, whatever it is. It's all about making the classes better. So, with that being said, you guys are
Miss
free to go.
Martinez, you said
Yes,
our remediation is due the 16th, but we
yes.
don't take the HESI until the 20th.
Okay, that's why. Okay, so because I put myself a week ahead. So we're in week 9, not week 10. So week 10, 11, 12. So it's the 23rd. My bad. Sorry. I just counted the wrong week. So yeah, just by that Monday at midnight. All right, you guys